Welcome to the Brain Matters webinar. I'm Dick Moberg, your host for today's presentation. Our featured panelist is Dr. Lori Shutter, who will be talking about the management of TBI patients. And instead of our normal industry partner, you'll hear from Dr. Anna Rodriguez on an exciting development called CarePath. As usual, we'll first review a few upcoming meetings and then get right into a recorded presentation from Dr. Shutter, followed by a short presentation by Dr. Rodriguez. At the end, we'll have a live question and answer session with our panelists, so please type in your questions using the Q&A tab on your screen anytime during the presentation. Now let's look at some upcoming meetings. All of these meetings are listed in the events section on our website, www.moberg.com. Starting this weekend is the American Academy of Neurology meeting right here in Philly. This is our hometown. Please stop by our booth if you need any help navigating the city, finding a good restaurant, or a great dive bar. We can certainly help. In June, we have the Neurotherapeutic Symposium with an all-star international cast of speakers. Then in June, the subarachnoid hemorrhage meeting, formerly the vasospasm meeting, this year in Amsterdam. Next is the neurotrauma meeting in Pittsburgh, the EEG technologists meeting in Kansas City, followed by the ICP meeting in Leuven. We'll be at all of these and hope to see you there. And now a few abstract deadlines. Here's some deadlines. I won't read them. Check them out on the recording of this webinar, which will be posted on our website within a week. This is a good time to remind you about our newsletter, the Neuroscience Monitor, which will keep you up to date in neuromonitoring. Your colleagues can sign up anytime on our website. If you have an event or news item related to neuromonitoring and neurocritical care, please send it to us. So to introduce our speaker, I want to do something a bit different, and we're known for that. For the next few seconds, I want to take you back in time to South Florida, where our featured speaker grew up.
A visit to Coral Gables, one of the world's most beautiful cities, may well feature a trip to the new campus of the University of Miami.
And you may stop at Pirates World and see little Lori Shutter enjoying the rides. And if you visited Coral Gables High, you might see Lori as a cheerleader. And if you needed your car washed, she might be helping. And just a short journey up the beach in Hollywood, Florida, you might see Dick Moberg on the beach. Little did anyone know that Lori and Dick would meet 40 years later at a head trauma conference and work on Boost 3 together.
So Lori and I grew up very close to one another, and we never knew it until recently. And with that introduction, I'm pleased to roll a video of her presentation, followed by a live Q&A.
Okay, so welcome everyone. Today we're going to spend some time talking about physiology-based management of traumatic brain injury. Particularly using some of the equipment that multimodality monitoring provides you to help guide therapy. With any presentation, there has to be disclosures. So I must say I'm a neurocritical care physician and I like physiology. Thus, I really like monitoring the brain. I'm also the clinical principal investigator for the Boost 3 trial, which was starting soon. This photograph on this slide, I always have to acknowledge the person who gave this to me. This was drawn by the husband of the woman lying in the ICU bed. While we give people pictures of how sterile the ICU can be and how everything is organized, this gentleman was dealing with his wife who had a grade 5 subarachnoid hemorrhage, and he was a graphic artist. So he sat there every single day in her room drawing all of the equipment in the room that we were using to monitor her. And it gave me a different perspective of what patients see and the chaos that they see, and something that I feel is organized and providing me lots of information. So objectives today, we're going to talk about how multimodality monitoring allows for identification of physiological parameters or variables in the brain and how it can enhance patient care. In particular, we're going to focus on brain tissue oxygen monitoring and how the changes in response to challenges or variations that we do, interventions we do at bedside, may give us insight in what is happening physiologically in the brain. And I'm also going to spend some time talking about how to actually perform these challenges as well as to interpret the information. So multimodality monitoring right now, as I mentioned already, ICP and CPP are standard assessments. We're used to them, but they give us late warning. There are other tools that are fairly common in the neuro-ICU, particularly EEG and continuous EEG. Some places are also looking at quantitative EEG and electrocorticography. Cerebral oximetry has been measured using different devices, both SJVO2 as well as brain tissue oxygen and near-infrared spectroscopy. Pupillometry and different devices to assess the pupils in a dynamic fashion have been introduced into the ICU. Cerebral blood flow is assessed through transcranial Dopplers and newer devices using both laser Doppler or thermal diffusion flowmetry. Microdialysis has been used in many research centers and in some clinical settings, and there's an increasing emphasis on trying to assess autoregulation using a variety of processed physiologic data. With all of these monitors, there are some problems. What we need is continuous real-time data that's easy to interpret. EEG and ECOG, unfortunately, have some difficulty with interpretation if someone is not skilled at reading that equipment. Autoregulation requires setting up informatics and processing of the data, calculating information after the fact. Microdialysis is delayed data. None of that is provided in a real-time fashion. Pupillometry and TCDs are just spot checks of physiologic changes. And what we have clinically available that is probably continuous in real-time data that is relatively easy to interpret right now is ICP data with the ICP waveforms and cerebral oximetry. So when we talk about the goal of resuscitation and patient management in the ICU, ABCs are still the primary focus of any resuscitation in trauma and neurotrauma. We want to provide adequate oxygen delivery to the organs. We want to avoid hypoperfusion, and the goal of both of these is to minimize or prevent end organ injury. So what brain tissue oxygen monitoring equipment do we have? While brain tissue oxygen monitors have been around for a while, the first that was FDA approved was made by Integra and was marketed as Lycox, and that was in 2000. More recently in 2007, Remedic has produced a piece of equipment called the NeuroVent, which is also a way to assess brain tissue oxygen. These devices measure brain tissue oxygen in about a millimeter cubed region around the tip of the probe or the catheter placed in the brain. There is actually no class 1 data that this information improves outcome, which has probably contributed to its variability regarding use in neuro-ICUs. So with brain tissue oxygen monitoring, the location of it is typically placed in cerebral white matter about 35 millimeters deep. Regarding which side it's put on, many people will state that it should be placed in normal tissue so you can avoid further damage to the brain. Other people will have suggested that it should be placed pericontusional to try to improve the perfusion and the oxygenation in that area. Normal values for brain tissue oxygen are above 20 millimeters mercury. When you have cerebral ischemia, the values are in the range of 8 to 12 millimeters mercury, and critical ischemia occurs at 5 to 8 millimeters mercury. we think that brain tissue oxygen monitoring measures O2 partial pressure in millimeters mercury in the interstitial space. As far as what it represents, there's been a lot of discussion whether it's the total oxygen delivery, whether it's cerebral oxygen metabolism, is it oxygen diffusion, or is it perfusion? In trying to determine what is actually measured by this, many groups have demonstrated that brain tissue oxygen actually correlates with end-tidal CO2 and with mean arterial pressure. In a fairly classic study in a small number of patients, but multiple variables were assessed here, the San Francisco group with Rosenthal and Hemphill et al. Actually looked at brain tissue oxygen monitoring with cerebral blood flow monitoring, and they did challenges using oxygen, mean arterial pressure, and CO2 challenges, during which they measured a number of variables listed here and to try to determine what the best association was. And from that work, they found that the best association of brain tissue oxygen occurred with cerebral blood flow times the arterial pressure of oxygen minus the venous pressure of oxygen. So the thought is that brain tissue oxygen may actually represent the diffusion of dissolved plasma oxygen across the blood-brain barrier and reflect the oxygen that's actually accumulated in the brain. This was one of the first times that a group used these challenges and reported on how to perform these challenges to assess physiologic responsiveness. So, rationale for brain tissue oxygen monitoring up to now. We know that episodes of low brain tissue oxygen occur after traumatic brain injury, and observational studies have shown that low brain tissue oxygen is associated with worse outcomes if there are no interventions to try to address brain tissue oxygen values. There are interventions that can rectify low brain tissue oxygen values. Increasing oxygen, CPP augmentation, and red blood cell transfusions have all been shown to improve these variables. There are some cohort studies showing that managing brain tissue oxygen in TBI patients may actually lower patient mortality. And there has been a study done, BOOST-2, that was published in 2017 that showed a treatment protocol aimed at treating brain tissue oxygen in traumatic brain injury patients was safe, feasible, and had a favorable trend on outcomes. This is just a result demonstrating the primary outcome was successful in that trial. Brain tissue oxygen was able to be maintained higher in the treatment group than the ICP-only group, which is the red line. When you looked at outcomes from these patients, there was a trend for improved outcomes. But this study was not powered to look at outcomes, and therefore nothing could be strongly stated regarding the impact of brain tissue oxygen management on long-term prognosis, long-term outcomes for patients. But this did provide enough support to move forward with BOOST-3, which is a phase 3 trial looking at brain tissue oxygen. Since this study is moving forward and there will hopefully be some demonstration as to the potential benefits of monitoring brain tissue oxygen, one of the goals is to try to increase clinical awareness of how to really become comfortable with the physiology that brain tissue oxygen can provide, with the physiologic information that brain tissue oxygen monitoring can provide to the clinician. Just to wrap up the BOOST-3 part, it is a randomized controlled phase 3 multicenter study. It is looking at a true pathophysiology in traumatic brain injury. And we won't spend any more time talking about BOOST-3 at this time, but instead the focus will be on how brain tissue oxygen helps us with knowing cerebral physiology. So these brain tissue oxygen challenges that I've referred to, they're interventions that can be performed at bedside, and they can assess both the reliability of the brain tissue oxygen data and they can assess cerebral physiology. The goal is to look at the response of brain tissue oxygen when these challenges are performed and use that to help guide clinical management. The challenges focus on adjustments of FiO2, mean arterial pressure, and CO2. So when a brain tissue oxygen monitor is placed, prior to insertion, the device should be calibrated according to the manufacturer's instructions. And once a device is in place, the probe should be assessed for reliability using an FiO2 challenge within 1 to 2 hours after it is placed. These challenges then can be repeated on a regular basis to confirm the reliability of the device. In general, if you perform any challenge, whether it be an FiO2, a MAP, or a CO2 challenge, no other active changes in patient care should be done. This includes, but is not limited to, adjustments in sedation, analgesia, drainage of cerebrospinal fluid, or any other physiological parameters, because you do not want to confound the response to the challenge itself. Once you have completed a challenge, whatever parameters you changed should be weaned back to the baseline level. You do not want to maintain patients at the extremes that are done during these challenges. So those are some general caveats to performing these challenges. So let's start with an FiO2 challenge. It's probably the most common one done in an ICU. It's familiar to a lot of intensivists. And it can assist in assessing both the probe reliability, as I already mentioned, but it can also provide information on both cerebral and systemic physiology. This can help guide ventilator settings for individual patients, and it can also provide insight on lung physiology. To perform an FiO2 challenge, the FiO2 is increased to 100% for 20 minutes or until the brain tissue oxygen increases by 5 millimeters mercury, whichever occurs first. You do not have to continue a patient on high levels of FiO2 for a full 20 minutes if your brain tissue oxygen has responded in the first 5 minutes. If the brain tissue oxygen levels increase as expected, you've confirmed accuracy of the readings and the functionality of the probe. If the challenge fails and the brain tissue oxygen does not increase, then the challenge should be repeated in about 1 to 2 hours to see if it will respond later. Minor changes, position changes, physiologic changes may cause some disruption, but before you give up on a probe and say that it is not working and it's not functional, you should repeat a challenge and make an assessment to see if the probe is positioned incorrectly. Again, as a reminder, at the completion of the FiO2 challenge, the oxygen level should be returned to the patient's baseline level. Measurements that should be assessed at the start and completion of an FiO2 challenge include brain tissue oxygen, ICP, oxygen saturation, and an ABG can be helpful to provide information on the PaO2 and the pH. You should also make sure you document these responses to these challenges because this will be able to guide your management of patients during the day. If your probe does not show an appropriate response and you're worried about malpositioning of the probe or failure of the probe, you should obtain a head CT to assess the probe position. It may have shifted, it may not have been placed properly when it was first inserted. There could have been expansion of contusions or increasing cerebral edema or any number of other potential causes for inaccurate brain tissue oxygen measurements. And a head CT can help assess that. So how do you perform other challenges? A MAP challenge can be done to assist in assessment of cerebral autoregulation. This is the poor man's assessment of cerebral autoregulation. It can guide both MAP and CPP goals in individual patients and can provide information on what is the potential optimum CPP for a patient on any particular day. To perform a MAP challenge, you either initiate or titrate a vasopressor if a patient is already on one to try to increase the mean arterial pressure, the MAP, by 10 millimeters mercury for approximately 20 minutes, or again until the brain tissue oxygen has increased by 5 millimeters mercury, whichever occurs first. Again, you do not have to continue the elevation in your vasopressor or the high MAP once your brain tissue oxygen has responded. Measurements to be recorded at the start and completion of any MAP challenge include brain tissue oxygen measurements, the ICP, the MAP, and the CPP. At completion of the MAP challenge, the vasopressor should be returned to its baseline infusion rate, or it should be stopped if you had used it just for the challenge. You do not want to maintain the patient on a higher MAP because that could cause a higher CPP and potential for secondary injury related to elevations in CPP. As far as the CO2 challenge, this can be done to assist in assessment of cerebral CO2 vasoreactivity to help guide ventilator adjustments and may provide input regarding potential hyperemia. This challenge can use either hyperventilation or hypoventilation based on the clinical situation. To perform this challenge, you adjust the respiratory rate by approximately 25%. It can either be an increase or a decrease in the respiratory rate, and then you move in little increments of 2 breaths per minute with a goal to either increase or decrease your PaCO2 by a maximum of 10 millimeters mercury. The duration of this challenge is approximately 20 minutes, or again until the brain tissue oxygen has responded by 5 millimeters mercury, either up or down, whichever occurs first. It is helpful to have end-tidal CO2 monitoring while you are doing this challenge, as both end-tidal CO2 and brain tissue oxygen monitoring should be assessed continuously to look at the response to these ventilator changes and the effect on brain tissue oxygen. Challenges should be terminated if the brain tissue oxygen approaches 15 millimeters mercury or decreases by greater than 50% of the value attained during any FiO2 challenge. The goal here is to not contribute to low oxygen in the brain by performing this challenge. Measurements to be recorded at the start and completion of a CO2 challenge should include brain tissue oxygen, ICP, end-tidal CO2, and an ABG for both the PaCO2 and the pH. At completion of the CO2 challenge, the respiratory rate should be returned to the baseline rate or adjustments made based on the data you've collected. At this point, we're going to move into case presentations, and we're going to actually discuss how you can use this information in a real life case scenario. So we're going to present cases and go through what this information tells you. So the first case, it's a severe TBI patient. The probes were just placed and your FiO2 challenge was done. At the start of your challenge, your brain tissue oxygen was 16, your ICP was 18, and your O2 saturation was 95%. You performed your FiO2 challenge by increasing your FiO2 to 100% for 20 minutes, and at the end, your brain tissue oxygen still read 16, your ICP was 17, and your O2 saturation was at 95%. What does this tell you? Well, in this situation, you had just placed the probes. These may represent that the probe has not yet stabilized itself, and you may not be getting accurate readings. In this situation, you would wait an hour and reassess the FiO2 challenge. So 1 hour later, when you go to get started, by this time, your brain tissue oxygen number is up to 19. Your ICP is 18, and your O2 sats are still at 94%. You increase your FiO2 to 100%, Your brain tissue oxygen within 10 minutes has climbed to 30, your ICP is 17, and your O2 saturations is 97%. What does this tell you? This tells you that your probe is reliable, the probe is functioning, and you may be needing to deliver a little more oxygen to increase your tissue diffusion of oxygen to get the patient optimized. But it did respond to this intervention, so you can gradually wean down your FiO2 and allow this to continue to stabilize. Or if as you wean your FiO2, the number begins to fall, then you have to try to determine what else may be contributing to a low brain tissue oxygen. So let's say in a second case, that was the perfect scenario, it responded appropriately. But let's say you did this, and instead of having a nice response, your brain tissue oxygen again did not go up. Your ICP went up slightly to 20, and your O2 saturation was still at 94%. So here you may want to look at additional information. What is your PaO2? If I bring up a ABG and it shows me that my PaO2 is only 75, that suggests to me that there is something happening systemically. So in this particular case, we got a chest x-ray and found that this young, healthy person had developed a pneumothorax between the time he had been admitted and this test. And his pneumothorax had contributed to him not being able to provide adequate oxygenation. While it was acceptable for the rest of his body because he had a healthy lung and had been a healthy person before his trauma, his brain cannot tolerate this lower level. By placing a chest tube in this patient and improving his lung status, his pulmonary physiology, you can then see an improvement in your brain tissue oxygen. So this is a situation where your information from your brain tissue oxygen can actually reflect lung physiology and lung pathology, and something you need to address. I have seen similar cases where a patient had developed trolley in the interim between a prior normal reading and a repeat FiO2 challenge in response to low brain tissue oxygen values. So you must worry about systemic changes as well as cerebral changes. So let's move to another day in this young severe TBI patient. It's day 3. His FiO2 challenge was done. He had a nice response and shows the probe is still functional today. So we did a MAP challenge on this patient. At the start of the challenge, his brain tissue oxygen was 22 with an ICP of 15. His MAP was 75 and his CPP was 60. We started Levofed. His MAP went up to 85, as you would expect. It went up relatively quickly, and his brain tissue oxygen responded nicely by also going up to 29. His ICP stayed the same, and his CPP also responded appropriately. So it rose in response to the MAP. This lets us know that there is some autoregulation preserved in this patient. He had an appropriate physiologic response to an increase in his MAP by increasing his cerebral perfusion pressure, but not having an increase in his ICP, although cerebral blood flow and oxygen delivery may have been improved with the higher MAP. This could be somebody that during the course of the day, if the brain tissue oxygen falls, we may be able to drive up his MAP slightly without harming his ICP and allowing better cerebral oxygenation. Let's bring up another scenario. So in this situation, the brain tissue oxygen rose slightly, only to 24, but your ICP climbed to 25. Your MAP did get up to 85, but your CPP was only 60. This situation would suggest impaired autoregulation. that there is poor compliance in the brain. The ICP rose with the elevation in the mean arterial pressure. The cerebral perfusion pressure did not respond appropriately. And this may be a brain that is hyperemic with impaired autoregulation, and driving up a patient's MAP or CPP is not a good treatment option for this patient. Another possible scenario is at the end of the MAP challenge, your brain tissue oxygen had climbed high. It went up to 29 with an ICP that went up a little bit, but not horrible, an ICP of 20. And the MAP went up to 85 as you had, your goal was, you achieved it, and your CPP increased to 65. This lets me know there's still some autoregulation, but while I drove up the mean arterial pressure, I drove up the MAP, cerebral blood flow increased, oxygen delivery increased, but the ICP also climbed. So I would be really cautious in this patient to make changes in CPP on this particular day, as I may be facing some problems with poor brain compliance or hyperemia or cerebral edema. Something else may be going on, and this may not be the best treatment option if this patient starts developing cerebral oximetry problems. If we move into CO2 challenges, again, same day, same values at the start. The patient's brain tissue oxygen is good, responded appropriately to the FiO2 challenge, and SATs are looking good. So let's try hyperventilating this patient. Because right now his end tidal CO2 is 38. We were aiming for normal capnia. We're in that range. So if we hyperventilate this patient and increase their respiratory rate, at the end of the first challenge with this, his brain tissue oxygen is 22. His ICP dropped significantly to 14, and you achieved your hyperventilation. Your end tidal CO2 is now down to 32. So you drove down your CO2, your ICP dropped with this vasoconstriction, and your brain tissue oxygen was stable. So the brain is well oxygenated. This is a scenario where hyperventilation could be used for ICP problems during the day. You may be able to transiently hyperventilate this patient should you see ICP problems and not cause oxygenation problems to the brain. Let's look for a second response. What else could happen with a hyperventilation trial? So in this situation at the end, you drove down the CO2 appropriately. Your end tidal CO2 was 32. Your ICP dropped with the vasoconstriction, as we had seen earlier. But in this situation, the brain tissue oxygen also fell significantly. This is a brain that isn't well oxygenated. It's kind of on the border. This is a patient I'd be very cautious to use hyperventilation for any period of time. I would try to maintain normal capnia in this patient. I would not want to contribute to cerebral ischemia and potentially cause further secondary injury to the brain or just cause low cerebral oxygenation. And so in this situation, this gives you some insight that hyperventilation is not on your list of treatment options for this patient on this date, or if it has to be used, it should be used very cautiously. Let's do another third case, another option of what could happen. You drive down your CO2 to 32. Your ICP dropped a little bit with the vasoconstriction, but not that much, went down to 18. But your brain tissue oxygen significantly increased. This suggests that the brain may be hyperemic, and the brain may actually benefit from lower cerebral blood flow for a period of time. And this is one where I'd go back and look at what my MAP challenge had told me and try to come to an understanding of whether I need to actually address some issues with hyperemia and cerebral edema in this particular patient. So some interesting information you can get from hyperventilation to help guide your treatment. Now remember I said that CO2 challenges can also use hypoventilation. So let's go through what you may see if you perform hypoventilation. So again, this patient was fairly normal capnic with a CO2, end tidal CO2 of 35, ICP is okay at 19, and your brain tissue oxygen was 23. So I performed the CO2 challenge. We drove up the CO2. As you can see, it went up to 42. The brain tissue oxygen increased with this vasodilation. So you may have allowed better oxygen delivery, and your ICP was stable. So this scenario would suggest that the patient could actually tolerate a higher CO2 and a lower respiratory rate, that you're not going to see higher ICP problems, that you may actually want to improve perfusion to the brain by making some adjustments in your ventilatory management and to allow slightly higher values of CO2. So that would be a good scenario. Let's look at another possibility. In the second case, again, you drove up your CO2. Brain tissue oxygen didn't really change much from the start. It's only at 24, but ICP actually increased. This is suggesting to me that the increased blood flow from the vasodilatation may be contributing to hyperemia. And this patient probably needs that mild hyperventilation. I would keep them in the range of 35 to 40 and allow them to have a little bit of vasoconstriction, to have a little bit of hyperventilation, and not increase their cerebral blood flow as much in this situation. Let's look at a third scenario here. Again, your end tidal CO2 responded to hypoventilation. It went up to 42. But here, your brain tissue oxygen actually fell with the vasodilatation. As you increased your cerebral vasoreactivity, as you increased blood delivery to the brain and oxygen delivery, brain tissue oxygen fell and your ICP increased very significantly. To me, this scenario would suggest that there's significant hyperemia in the brain or cerebral edema, and this brain is not compliant. This patient may really benefit from a period of hyperventilation, lowering both perfusion and oxygen delivery, and address any potential cerebral edema. So this patient may need a little more assessment, whether it be through imaging or other modalities, to get a sense of what is going on physiologically and how to optimize their care. So these are some of the responses you can see, and documenting these to share with the rest of your team can be helpful so that other members of the team can have some idea of responses during the course of the day and how this patient may respond to management decisions. When we manage patients, we often think of this combination of both elevated ICP, normal brain tissue oxygen, or low brain tissue oxygen, and we can divide patients up into different scenarios and look at the combination. Is this patient having both good ICP values and good brain tissue oxygen values? Are they having elevated ICP, but brain tissue oxygen is fine? Are they having low brain tissue oxygen, but a normal ICP? Or are they having both low brain tissue oxygen and high ICP? So you can guide your therapy based on which scenario the patient may fall in. The treatment options that you should do in scenario-based management should be based on what would be the most effective for the current clinical situation, the patient characteristics, and your local protocols. Any intervention should be aimed at addressing the underlying pathophysiology that's contributing to each individual episode. Thus, your response may vary based on what you had learned from your challenges during the course of the day and how you feel this patient is responding to changes in FiO2, MAP, or CO2. For any treatment given, a rapid response to that treatment should be expected, and if a treatment is not effective in a timely fashion, additional intervention should be attempted or a decision made to quickly reassess physiology and potentially repeat some of your challenges. Next slide is just a slide showing some of the different things you can do to address patient situations that are scenario-based. I'm not expecting anyone to read this, but you should have a local protocol and local ideas of what you would do in response to ICP elevations, brain tissue oxygen decreases, and those happening either in isolation or together. Having a tiered approach based on different clinical scenarios may allow you to optimize your patient management. So in summary, multimodality monitoring can provide insight in brain physiology. Brain tissue oxygen monitoring provides information on the pathophysiology seen in traumatic brain injury. And responses to these physiological challenges may be able to help guide your treatment in a patient-specific manner. So having this information available can help guide you to have scenario-based management that should address a patient's individual needs. And with that, we will open this up to questions.
So thank you very much, Lori. Please get your questions ready for the live session using the Q&A tab on your screen. While you're doing that, we have a message from Anna Rodriguez, who will give you a quick description of CarePath and how it's used in Boost.
Hi, I'm Anna Rodriguez, and I want to tell you about CarePath, which is software we have been developing to provide compliance to both research and clinical protocols, as well as increase the consistency of care. It's been used in the Boost 3 trial. In CarePath, clinical pathways are represented electronically in a language we developed, and the patient's physiology, as recorded by the CNS monitor, drives you through the flowchart. Along the way, instructions are provided to help you carry out the tasks in each box. It also provides the ability to provide annotations as to what was done, so it's pretty simple. And now let's look at an example. We'll show you how CarePath is used in Boost 3. A flowchart is derived from the Boost 3 protocol using the language we created, and scripts are written to recognize the changes in ICP and brain oxygen that determine the 4 categories of therapeutic actions. In this example, we show CarePath detecting high ICP and low brain oxygen. When this happens, a notice appears that an intervention is required. Pressing the intervention button brings you to the right box of the flowchart. And here you see the various interventions available for this tier of treatment. Upon selecting an intervention, the details of how to carry out that intervention are displayed. And the user can press a button to know that the task was done. This creates a high-resolution record of what was done to the patient, and you can see that on the side. This record can be used as an audit trail for the trial, as an adjunct to the medical record, and for further research as well. Let us know if you have any ideas for further applications of CarePath.
Thank you, Anna. Before the Q&A, I wanted to let you know about our next webinar. It's on neonatal neuromonitoring featuring Dr. Lena Chalik. So please register for this on our website under the Events tab. And so please get your questions in, and we'll now go live to Dr. Shutter in downtown Pittsburgh. So Lori, you can turn on your camera and your mic.
I have turned them on.
There
Not
you
sure.
are.
Okay.
And I want to just open that up and thank you for sending those wonderful pictures of you in South Florida. I had a fun time putting that together, and I got to relive a lot of great memories from growing up down there. So thanks for that.
Yeah, thanks for embarrassing me. Great. Okay.
You and me both.
Long time ago.
Thanks a lot. So you can just go through the questions and answer them as you see them on the Q&A tab. Thanks.
Okay. Someone asked me whether I'd be willing to make the slides available. Dick, I don't know what your policy is on making them available, but if anyone wants to reach out to me directly, I'm more than happy to share that information. I have shared it already with a number of people. I think trying to have discussions about case-based management is an important teaching point. So yeah, just drop me an email. And it was on the slides, but if you need it, again, it's my last name, Shutter, SHUTTERLA, all one word, at upmc.edu. A question came up of, could I share my thoughts on what limitations there might be by monitoring brain tissue oxygen in the less metabolically active white matter, and what that can really tell us about oxygen demands and supplies of the gray matter? That's a great question, and recognize that the white matter is less metabolically active. I would say that we have the current values of what's considered normality in brain tissue oxygen has been based on a lot of background research. Most people say that in normal white matter, brain tissue oxygen is actually around 15 millimeters mercury, but many people have adopted the 20 as a marker for injury to try to increase some of it. This is probably not a good marker of the metabolic demands of the gray matter, and this is where other components of multimodality monitoring may be helpful. Information from EEG to give you an idea of activity, but we don't really have any great markers that I'm aware of right now of gray matter metabolic activity. So I do think it has limitations, but right now it's one of the best tools we have to give us some answer of physiology. And if people want to respond to that, that'd be great. Another question came up of, the scenarios are interesting to define immediate physiology, but your recommendations fly in the face of recommendations to maintain eucapnia unless there's an immediately surgically correctable acute ICP elevation. Eucapnia is the range of 38 to 44. Generally, there are some places that actually maintain TBI patients with a range of 35 to 40 and consider that a relatively normal range. So again, I think you have to look at what the brain is asking you for what it needs at any point. And there are some cases where hypercapnia, or actually hypoventilation, is used for lung trauma. So what if this patient had ARDS or had pulmonary contusions? Your trauma surgeons may want to allow your PCO2 to climb. The traditional idea is, no, with TBI patients, keep it around eucapnia or even a little bit lower, 35 to 40, but maybe having information from brain tissue oxygen would allow you to say, maybe I can tolerate a slightly higher PCO2 of 44 or even 45 that may be more in keeping with what the lungs might need at the time. So there's a difference between mild hyperventilation and maintained significant hypoventilation. I'm never saying to take people down around a PCO2 of 30 or less. That has definitely fallen out of favor, but there are definitely places that use the range of 35 to 40, and it's based often on local protocols, and the brain tissue oxygen can give you an idea of what might allow what this patient may tolerate on any given day. Okay. The question came up about the amount of time. Based on what device you use, there are variable recommendations regarding placement of the device and performing your first FiO2 challenge. Most of the equipment currently available says that you should wait at least 60 minutes after placement of the brain tissue oxygen probe before you do an FiO2 challenge. And I think that is a good range to wait for 60 minutes to let things stabilize. There is some equipment that may need up to 2 hours. So if you do a challenge at 1 hour and you are not seeing an appropriate response, I would actually wait another hour or so and then repeat it and see if it's working. And yes, the FiO2 challenge is probably my very first test to determine if the monitor is reliable and if it's working before I do anything else, before I go off to a head CT or do anything. Put that in, wait about an hour, see what your number is. If it's already gone up to over 20, then you know it's working and you don't need to necessarily do the FiO2 challenge. But if it's still a little bit low, I would usually do the FiO2 challenge just to make sure that it's responsive. We have a question, is there a role for placing probes at 2 different sites, one at the site of brain injury and the other at the normal site? I would, there's a part of me that would love to have a cap that went over the head that gave me an idea of what brain tissue oxygen was everywhere. So if a neurosurgeon, if one of my colleagues was willing to put in 2 probes, I would be interested in the data. It might help with knowing how to best optimize the injured brain, and keeping it in the more normal appearing side has, would allow you to maintain that normality. The problem is, of course, you are drilling another hole in the skull, and there are risks with that. So it would again depend on your local protocol and whether there would be benefit. In the research lab, there are times where we place more than 1 brain tissue oxygen probe to get a sense of what is happening between the hemispheres, and there can be variability based on the injury pattern. As far as putting it in injured brain, healthy brain, or the injured brain, at our site here, we try to place it in the most normal appearing brain. One of the reasons for that is if you put it in an area of contusion, contusions often expand. And while it'd be great if you could get it in the penumbra, on the edge of the injury, especially in trauma, as that changes, as you develop brain edema, you may end up actually getting into non-viable tissue or into a contusion, and then your information, your values are not accurate, and that you can't reflect well on what's happening in other places. So that's why a number of places will tend to put it in the most normal appearing brain. But again, I have seen places try to put it in a pericontusional area, but my personal concern would be that with blossoming of a contusion with potential for edema, that you may have some changes in the probe may not provide you good information. I have used brain tissue oxygen in subarachnoid hemorrhage. I have used it in locations that we're worried about for vasospasm. It probably can provide information. Our current practice here at Pittsburgh is that we don't place this. I have worked at other places where we actually did. I do think it can provide you significant information. I'm not going to recommend placing it in a grade 1 or 2, Hunt and Hess grade 1 or 2. Those patients are awake. I can follow their exam. Where I have placed this is placed a brain tissue oxygen monitor is in a severe subarachnoid hemorrhage where I don't have a good exam, and this provides me more physiologic information. I also know of places that are placing these monitors routinely in subarachnoid hemorrhage, and also we have placed it in patients post-cardiac arrest, and I know of other sites that are doing that as well. In those cases, again, probably going for either the most normal appearing brain or a non-dominant hemisphere, the right frontal lobe, has been usually the standard practice, other than the situation where you may be able to predict vasospasm, and then you might want to try to place it in the area at risk. I talked about parameter modulation on any given day. The brain response will rapidly attenuate. So this is one question. I'm sorry, I'm reading it out loud. You also speak about parameter modulation on any given day, but the brain response will rapidly attenuate from any changes in PaCO2 that are maintained for whatever period of time. This does not make sense to me unless you're proposing constantly changing the ventilation of a comatose, not spontaneously breathing patient. I'm not suggesting that you're constantly changing it. I'm suggesting that this information may provide you some insight in how the brain is responding to those changes in your PaCO2. And you can use that to help guide your management and where you want to maintain a patient. And I recognize that it can change rapidly. Those minor fluctuations the brain can probably tolerate, and brain tissue oxygen may not change significantly. It's more when you see problems with elevated ICP or with low brain tissue oxygen to try to give you some idea of what may be contributing to that and how can you modify things to try to minimize any kind of secondary injury. How long, so a question, how long the monitoring be performed if the ICP are not controlled? If the ICP is not controlled, I continue to monitor the patient as through that time period while I'm trying to control ICP. The standard right now per the TBI guidelines is that ICP is still the primary focus. Brain tissue oxygen can be a tool to help you manage things and help guide your therapy, but your focus should still be on ICP management. So this device can be in place while you're monitoring ICP, but your goal should be on making sure your ICP is controlled. Personally, I have kept an ICP both ICP and brain tissue oxygen monitors in place up to 10 days. I will acknowledge that the FDA in the United States says that any intracranial device should only be in place for 5 days. That's all any device is approved for, but it's not uncommon for us to maintain devices in place for time periods up to 7 to 10 days. I've seen a few other, okay, another question, is hypothermia an effective way to control brain tissue oxygen and ICP? What temperature do you always use? Here, our normal protocol is to aim for normal thermia. So we try to keep people between 36.5, 37 degrees in that range. Hypothermia has been used to help control ICP and brain tissue oxygen. It decreases metabolic activity. It may be beneficial, but I think you have to do it on a case-by-case basis to see if a patient will respond to that. It should not be used prophylactically. We have lots of data saying hypothermia does not help manage ICP when used prophylactically, but on a in certain cases or in refractory, it is a treatment option. It is often considered a tier 3 treatment. and you may see improvements with both ICP and brain tissue oxygen. But I would not maintain them being hypothermic. I would just go to that as a treatment modality. Otherwise, I would try to avoid fevers and maintain normal thermia. Were there any other, those were the questions that have come up. Any other questions from the group? I think we have some chat questions. Okay, that came up on the question. So most of the chat I have seen on the in the question. So if, let me see, one more. Oh, yes, hold on, another question. Okay, I will wait. I also am more than happy to answer questions directly if people want to reach out to me. I do think patients that have chronically elevated PaCO2 may have different responses to the brain, and one advantage of our Boost 3 trial is that we will be able to gather some of that information and try to see how the brain tissue oxygen and the PaCO2 responds, because all of that data will be gathered in this study to assess responsiveness and to have some idea of what a patient's baseline status is. And if, like I said, if people want to ask me direct questions, I'm more than happy to discuss this and spend a little more time going over things. My email again is shutter, SHUTTER, LA @upmc.edu. So Dick, I think we're a little bit after 2. Is there anything else we need to do right now?
No, I think that's it. Thank you so much for taking your time to do this webinar. According to the number of participants, it was one of our more popular ones. And I think that's a testimony to the excitement you've created through Boost 3. And we're all anxiously looking forward to getting that going. So again, thank you very much, Lori. And thanks to all of our viewers, especially those in Europe who are listening to this late on a Friday evening. And again, thank you all, and we'll see you at our next webinar.